Hello students, welcome to the session. I am Dr. Ravirna Reddy, your medicine faculty at Medico. Today we are doing test and discussion in medicine. So as we have already discussed, we can read medicine in two ways. You can read and do the questions. Here we are taking up the questions and we are picking up the keywords, integrating them with the presence of mind, and we are getting an answer, and then we are discussing about the whole concept. This is what you have to do in the exam. In exam, you have divided sessions, so time management is more important now. So to answer a medicine question, you should pick up a keyword which will give you the answer. So it's not that easy to pick up a keyword. For that, you should develop integration. For developing integration, you should follow your source strictly, you should revise it and apply on more questions. Only then you can develop that integration, and you should need a presence of mind in the exam. Only then you can integrate. With this, you will get a better precision with the options. The same thing we'll be doing now. We'll be taking up each question. So I have taken question from each important topic of medicine, and we'll discuss the question, get the keywords, integrate, get the answer, and discuss the important concepts of those topics. So we are not following any system wise. We'll be taking random questions and discuss. Let's start with the first question. So this patient is having symptoms of fatigue, kidney stones and bone pain. So bone pain, renal stones, fatigue with elevated calcium and elevated PTH. What is your diagnosis? So calcium is elevated, PTH is also elevated. Is it primary hyperparathyroidism or secondary or tertiary hyperparathyroidism? It is primary hyperparathyroidism. Your parath hormone is elevated, calcium is elevated, and phosphorus is decreased. This is primary hyperparathyroidism. Whereas your calcium is decreased and phosphorus is increased. Because of that, to compensate, loss of negative inhibition will lead to increased parath hormone. That is secondary hyperparathyroidism. And coming to tertiary hyperparathyroidism, a case of constant secondary hyperparathyroidism, your parath hormone will be releasing autonomously without any calcium or phosphorus regulation. See, in secondary, calcium is low. That is why parath hormone is increased because of loss of negative inhibition. But what happens in tertiary is, whatever the calcium, whatever the phosphorus, I don't care. Parathyroid gland will be like, whatever may happen, I will release parath hormone constantly. So it is autonomous. I'm not inhibited by anyone. I will do my autonomous production. That is tertiary hyperparathyroidism. It is autonomous production of parath hormone due to loss of secondary inhibition, and calcium will be high, phosphorus will be high, and the only condition where you will be seeing tertiary hyperparathyroidism is your CKD. Only condition on earth that will cause tertiary hyperparathyroidism is CKD. I think it's clear. Parath hormone, for suppose there is a pathology in the parathyroid gland, for suppose parathyroid adenoma, parath hormone is released. Because of that, calcium is increased and phosphorus is decreased, that is primary. Due to some pathology, there is hypocalcemia or hyperphosphatemia in the body, and due to loss of secondary inhibition, there is increase in parath hormone production, that is secondary hyperparathyroidism. Whatever the calcium status and phosphorus status of the body, I don't care. That is the status of the parathyroid gland releasing amounts of parath hormone into the body. That is tertiary hyperparathyroidism seen only in CKD. So this condition, elevated PTH with elevated calcium, is primary hyperparathyroidism. Some abnormality with the parathyroid gland, you have to examine for the parathyroid glands and do some imaging to look for the parathyroid glands. And these patients are having fatigue, kidney stones and bone pains. So what they will be having: stones, kidney stones, moans, psychiatric moans, groans, abdominal pain, all these things they'll be having, right? These are the symptoms of hypercalcemia. What is the most appropriate initial management of the condition? So these are the key points. Your calcium and parathyroid is the key points. You got the answer as primary hyperparathyroidism. They are asking management. So you should read the question properly. That is why the presence of mind in exam is very important. He's asking most appropriate initial management. Most appropriate management is different. Most appropriate initial management is different. The most appropriate initial management for hypercalcemia is fluids. You have to give IV fluids. Why IV fluids? Because of calcium being excreted into the urine. It will act like a diuretic. It will bring more water with it, and this patient will be having polyuria and polydipsia. So they will land in dehydration. So first you have to treat the dehydration. Then the second step will be you can give bisphosphonates. Then the ultimate best step, the most appropriate step is parathyroidectomy. The most appropriate initial step is IV fluids. This is the treatment of choice. Vitamin D supplementation. For suppose because of vitamin D deficiency, there is calcium is low, and because of that parathormone is increased. That is secondary hyperparathyroidism. There is secondary hyperparathyroidism due to vitamin D deficiency. You can give vitamin D supplementation, but here there is no role. So if the question is most appropriate, the option is C. But here the question is most appropriate initial management, so the option will be A. So coming to hypercalcemia. What are the causes of hypercalcemia? You have seen one thing, parathyroid related. Due to increased parathormone, it can happen. And the second thing is malignancy. It's the most common paraneoplastic syndrome. In malignancy, it can be because of paraneoplastic syndrome, or it can be because of the bone lytic lesions. Or in some malignancies like multiple myeloma. What do you see in TLS? In tumor lysis syndrome, there is hypercalcemia or hypocalcemia. Tumor lysis syndrome has hypocalcemia, whereas the malignancy with bone involvement or the malignancy with paraneoplastic syndrome can present as hypercalcemias. Or it can be vitamin D related, vitamin D excess. So how there is vitamin D excess? One thing is you can take increased intake or increased tablets of vitamin D, syrup or tablets of vitamin D. What can be the other possibility? Is there any disease in which the pathology of the disease will produce vitamin D? Yes, it's sarcoidosis. In sarcoidosis, the granulomas will produce vitamin D. And some lymphomas, they will produce vitamin D. So your vitamin D is two forms, 25-hydroxy and 125-dihydroxy, right? And in sarcoidosis, it is 125-dihydroxy vitamin D which is increased. Okay? And the next thing is increased bone turnover. And associated with renal failure. These are all the causes of hypercalcemia. In exam, for suppose he is asking you. And hypercalcemia, what are the ECG changes? It is short QT interval, right? How do you treat? Just now we have discussed. Coming to the treatment, The first step is to give IV fluids and diuretics. The second step is to give bisphosphonates, but the ultimate best step is the parathyroidectomy if the origin is parathyroid. For suppose it's because of vitamin D excess, there is no point in doing parathyroidectomy. Okay. Coming to the next question. Which of the following is the primary difference between type 1 and type 2 diabetes mellitus? So he's asking the difference between type 1 and type 2. Here you don't have to search the key points in question, but the options, the key points are important. So coming to what he is asking, difference. So he's asking the true statement. So these true statements and false statements are the ones being confused. You should read the question properly. He'll be asking not false, not true, true except, false except. So from the question you should derive that you have to select a true statement or false statement. Just write it like that. And every statement you mark it. So first one, type 1 diabetes is insulin resistance and type 2 is because of destruction of beta cells. No, it's exactly the opposite. It's false. Type 1 is diagnosed in adults and type 2 in children. Is there like that? Yes. Type 1 is a bit younger age. Type 2, from adults to elderly, anybody can be affected. Here it's opposite. Type 1, you need insulin for management. Yes, because type 1 is because of the damage of your beta cells, you have to give insulin. Most of your oral hypoglycemic drugs are insulin secretagogues. They will act on the pancreas and make it produce more insulin. But here there are no beta cells. By giving oral hypoglycemic agents, there is no point in type 1. In type 2, there are some beta cells, so there is point in giving oral hypoglycemic agents. So type 1, you have to treat it with insulin, and type 2, you can try with oral medications and lifestyle modifications, and not responding to that very high sugars, you can go for insulin. This is absolutely true. Coming to the last statement, type 1 is associated with obesity while type 2 is not. See, type 1 is because of the autoimmune destruction of beta cells. Type 2 is because of insulin resistance. Obese people with sedentary lifestyle, with hyperlipidemias, only they will have insulin resistance. So it is also an exact opposite statement. So type 1 and type 2, I think you know the differences now. So type 1, younger age, they are mostly thin. Phenotype is they will be thin and they will need insulin, and the presentations are usually drastic. They can present with diabetic ketoacidosis. Type 2, the presentations are very simple or incidentally they will be detected with diabetes, and the phenotype is they will be having obese phenotype. And type 2, initially you can manage with lifestyle modification and food modification. Later you can add oral hypoglycemic agents, combinations also you can go, and not controlled on that you can go for insulin. So coming to the acute complications of diabetes, there are many complications. If you say chronic, there is microvascular, macrovascular, many things, but acute complications of hyperglycemia, there are two things. It is diabetic ketoacidosis and hyperglycemic ketotic coma. This is hyperglycemic hyperosmolar syndrome and diabetic ketoacidosis. These are the acute manifestations or acute complications of diabetes. You should know the difference between presentations, because in question, they can give you one presentation and you have to select one. So your diabetic ketoacidosis, first let's discuss about DKA. The name itself saying that DKA, diabetic ketoacidosis. It is saying that the patient is diabetic, there is ketosis and there is acidosis. So how do I diagnose this? Blood sugars more than 250. Either blood ketones are specific, but usually bedside will be doing urine ketones. Urine or blood ketone body is positive. And there is acidosis, that is high anion gap metabolic acidosis. If these three things are there in a case of diabetic ketosis, because of ketone bodies there is acidosis, I am going to diagnose it as DKA, and this is one of the acute complication occurring only in type 1 diabetes. You don't see decay in type 2 diabetes? So what is decay? It is hyperglycemia, ketosis and metabolic acidosis. As usual, we have discussed. So why there is ketone bodies production in diabetes? We will see. So what's happening in diabetes, especially type 1 diabetes? In type 1 diabetes, your beta cells in the pancreas are destructed. So there is a decreased insulin. And due to some stress, the stress can be fever, the stress can be MI, cerebrovascular accident, anything. Because of that, there is increased glucagon. And because of decreased insulin and increased glucagon, there will be lipolysis. And this lipolysis releases free fatty acids which will be converted to ketosis. So the fatty acids are converted into ketone bodies. The ketone bodies are nothing but they will add to acidosis. They are ketone acidotic bodies. They will cause high anion gap metabolic acidosis. And one more thing is, because of decreased insulin, there is decreased glycolysis. So more sugar, increased gluconeogenesis. So glucose is not degraded, more glucose is formed. So your sugars also will increase. There is hyperglycemia. So more sugars in the urine, it will act as a diuretic, it will draw more water through the urine. So these patients will be having polyuria. That is why there is osmotic diuresis. And when there is polyuria, they will land in dehydration. In the case of DKA, the patient will be dehydrated like anything and he needs almost 5 liters of fluids. So just because of decrease of insulin and increase of the counter-regulatory hormone, that is glucagon, the mechanics of the body is changed. There is lipolysis, more fatty acids which are converted into ketone bodies, and more glucose production which is causing more hyperglycemia and dehydration. So these things are happening here. How do you treat a case of DKA? Coming to treatment of diabetic ketoacidosis, what is the first thing you do? So emergencies, you should know what is the first step, what is the last step, to what is the best step, because the questions are like that. He will ask most appropriate management or most appropriate initial management. Sometimes he'll give you some management and he'll ask you what is the next step. Those are the things you will be confused, and such things he'll be asking in emergencies only. So emergencies, you should know what is first. So DKA, the first thing is, you would have treated many DKA cases in your EMDs, emergency. It's IV fluids. These patients are severely dehydrated and they need at least 5 liters of fluid. Give 3 to 5 liters of fluid. What is the best fluid? Go for half NS. What is the next thing you want to do? Your sugars. You have to decrease the sugars, right? So to decrease the sugars, you will give IV insulin. See, the thing is, insulin you will be giving subcutaneous only. Whether it's diabetes or anything, you will be giving subcutaneous only. There are only 2 conditions where you will be giving insulin IV. One thing is DKA, and do you know any other thing? What are the indications of IV insulin? The first thing is DKA. What is the second thing? It is your hyperkalemia. So these are the 2 emergencies where only we will use insulin as intravenous. Any other setting, you will be giving insulin as subcutaneous. So here we give IV insulin. But why I wrote it as a third step? Because before giving insulin, you have to look at the potassium of the patient, and if there is hypokalemia, you have to give potassium and then give IV insulin. See, we are using insulin as a treatment of hyperkalemia. So Insulin will cause hypokalemia. If the potassium is low and you are giving insulin, you are precipitating hypokalemia. So before giving insulin, make sure the potassium is normal. If it's low, give potassium along with the fluids and then go for insulin. So what's the first step? IV fluids. Second step, look at the potassium. If low, correct it. Third step is give insulin. You may ask me one more doubt. There is acidosis. So can we give bicarbonate? No. If you give IV fluids and you give insulin, the acidosis is automatically corrected. Whatever the acidosis is, you give IV fluids, it will be corrected. But if there is severe acidosis, that is pH is less than 7, your blood pH is less than 7, that is the indication to give bicarbonate to the patient. So give bicarb only if the pH is less than 7. And last but not the least step, look for any precipitating factors. I've seen a case of diabetes, type 1 diabetes, a bit elderly, with deterioration, that he came with DKA and his ECG was showing MI. So the precipitating factors can be anything, can be MI, can be cerebrovascular accident, can be a little fever or anything. So you have to look for the precipitating factor and correct it. Otherwise, the precipitating factor will again precipitate DKA. It's the last but not the least. So the treatment of DKA is fluids, at least 3 to 5 liters. Look at the potassium. If low, correct it. After that, give IV insulin. And then bicarbonate should be given only if the pH is less than 7, that is severe acidosis, and correct the precipitating factor. Now you know what is DKA and why it's occurring, how to correct it. Now what is this 300, maybe 400? But in hyperglycemic hyperosmolar syndrome, the sugars are very high, almost 600. The blood sugars are almost more than 600, and because of that there will be constant polyuria, and this patient is more severely dehydrated. The water is lost from the body and the blood will be hyperosmolar. So hyperglycemic hyperosmolar syndrome. There is no ketosis and acidosis. So how do you treat this? So DKA, it is acute. Today, just from half an hour, patient will have abdominal pain, he will be having altered sensorium, and he will be bring to the EMD. Whereas HHS, it's usually elderly female, for 4 to 5 days she is on the bed, or some few weeks she is on the bed, not getting up, in altered sensorium. That will be the history. So the history will be a bit subacute here. Whereas DKA, it's acute blowy presentation. And how do you treat it? It's a simple dehydration, give fluids. It's just IV fluids. And DKA, it was 3 to 5 liters deficit, right? Here you should give almost 6 to 10 liters of fluid. And you have to give insulin to correct the sugars. That's it. No bicarb, no acidosis correction, and you can look at the potassium. So this is HHS versus DKA. Now you know the difference, why it's occurring, what's the presentation, how to treat it. Okay, let's take up the next question. Next question. This patient is having central obesity, hypertension, and purple striae. So there is obesity, purple striae on the body, and hypertension. Can you think of any disease? Okay, just keep it in the back of mind. Let's go further with the question. It's saying that there is elevated cortisol levels and suppression of cortisol following a low dose dexamethasone suppression test. What is your diagnosis? So definitely this is Cushing's hypercortisolism. It's Cushing's syndrome because of hypercortisolism. That we can understand because the cortisol is increased. Now cortisol is suppressed with low dose dexamethasone suppression test. What is your inference? So your Cushing's, the cortisol origin can be primary, that is ACTH dependent or independent. ACTH independent or dependent. ACTH independent means it is coming from the adrenals. ACTH dependent means two possibilities. What are the possibilities? It can come from pituitary or a ectopic. So the first step is you have to look at the ACTH. ACTH is low or high. If ACTH is low, that means it is ACTH independent. If ACTH is high means that is ACTH dependent. And if it's suppressed with low dose dexamethasone, it doesn't mean anything. It's just true hypercortisolism or Cushing's disease. So in the question, a part is missing. What is that? He should have mentioned about the ACTH. So ACTH is normal. If they say ACTH is normal, then it's adrenal adenoma. If say ACTH is raised, it's definitely not primary adrenal insufficiency. If they say ACTH is raised, and suppressed by high dose dexamethasone, it's pituitary. Not suppressed by high dose dexa, ectopic. So here if you want the answer is Cushing's disease, what is the part missing in the question? It is high dose. That should be the correct thing. I will explain you once again. I know it's a bit confusing. First, let's see what is Cushing. What are the causes of Cushing's? What is ACTH dependent, independent? What is low dose and high dose dexamethasone test? These are the things you should know about Cushing's. 4 points. Let's discuss that. And after that, we'll come back to the question and discuss. It's confusing, right? So first, let's see what is Cushing's. Cushing's means there is increased cortisol in your body. Because of that, there are some changes. Cushing's phenotype. What is that phenotype? Increased cortisol. So because of increased cortisol, what is happening to your carbohydrates? There is increased glycogenolysis and decreased glycolysis. So ultimately more glucose is produced and there is hyperglycemia. Next, what is happening to your lipids? Lipids, there is lipolysis. The fats are being lipolyzed and there is redistribution of fat. Redistribution of fat. The fat is redistributed from the periphery to the central. So that is why there is central obesity. The person will look like this. Lemon on stick appearance. What is happening to the proteins? There is proteolysis. So because of proteolysis, first thing, your muscle mass is decreased. And sometimes there can be myopathies, pathology with the muscle and muscle weakness. And what is there in your skin? The collagen, it's also protein. So there is lysis. Because of the lysis of the collagen, your skin will become friable. If you touch the skin, there will be a contusion there. Next, your cortisol also has some mineralocorticoid effect. Because of that, there is increased sodium and water absorption. Excuse me. Because of the mineralocorticoid action, increased sodium and water reabsorption into the body. And potassium and H+ is lost out of the body. Because of sodium and water reabsorption, these patients are having hypertension. Because potassium and H+ is lost, there will be hypokalemia and alkalosis. Very simple. You don't have to by heart that there is central obesity, there is purple striae. Why purple striae? The same thing. The skin, the collagen is absent, the skin is friable. That's why. Now let's see the pictures. The first picture is showing the central obesity and there are purple striae on the abdomen. This is also a purple striae. This is showing that the skin is friable. If you touch the skin, there will be contusion. And there is hyperpigmentation if you look at this picture. If it is if it's secondary, that is ACTH dependent, from the pituitary increase ACTH acting on the adrenals releasing more cortisol. Because of ACTH, there will be hyperpigmentation. So this is Cushing's presentation. Okay, now let's see why there is Cushing's. Why cortisol should be excess? So the cortisol can be produced from the adrenal gland directly, or it's because of ACTH which is acting on the adrenal gland and releasing cortisol. So it's ACTH independent and ACTH dependent. Now you know the terminology dependent and independent. And most common is ACTH dependent only. The first cause is Cushing's disease. A pituitary adenoma which is releasing, a pituitary adenoma releasing growth hormone, acromegaly. A pituitary adenoma releasing prolactin, prolactinoma. The same way, a pituitary adenoma releasing ACTH is your ACTH dependent Cushing's disease. That is called Cushing's disease. Cushing's syndrome is all things we have explained. Moon-like face, buffalo hump, there is lemon on stick appearance, central obesity, purple striae, the fat redistribution, everything is Cushing's syndrome. If the Cushing's syndrome is because of the pituitary adenoma, it's called Cushing's disease. Or the ACTH can be produced from a tumor, for suppose a small cell carcinoma of lung, or suppose from bronchial carcinoma that's releasing ACTH. Your ACTH not only comes from the pituitary, can also from some malignancy. That is ACTH dependent. ACTH independent is your adenocortical adenoma, adenocortical carcinoma. You understood, right? Now that you know what is Cushing's syndrome and what are the causes, now let's go for the evaluation. And this evaluation is beautifully given in Harrison, so that is why I'm bringing that table and discussing. One table, you know the whole evaluation. It's the most confusing part, but just understand why we are doing each test, then it will be easy for you. So once there is a clinical suspicion of Cushing's, So there is moon facies with buffalo hump, and there is purple striae, central obesity. Patient is having hypertension, hyperglycemia. You think that, okay, this patient is looking like Cushing's syndrome. Next step, what will you do? For next thing is you have to confirm or screen for the diagnosis. So here I am doing a screening test. What screening test? Cushing's is because of increased cortisol. So I will check for cortisol. So I will look for urine cortisol, midnight salivary cortisol. So I will check for cortisol in salivary cortisol or urine cortisol or early morning serum cortisol also you can check. And one more important screening test I am doing is low dose dexamethasone test. What is low dose dexamethasone test? I will give 0.5 mg tablets of dexamethasone every 6 hourly for 2 days. So 2 days, every 6 hourly, that is 8 tablets of 0.5 mg dexa he should take for 2 days, and he should come to me. After that, I will check for serum cortisol. So if you take dexa, that will suppress ACTH and your serum cortisol should be suppressed. If it's suppressed, that means it's not Cushing's. So negative means it is suppressed and it is pseudo Cushing's. What is the pseudo Cushing's? See, a patient of depression will also look like that. A patient of hypothyroidism also will look like this. So it can be other cause which is looking just like Cushing's, but it's not Cushing's. With low dose dexa, it's not suppressed, the cortisol is still high, then comes our true Cushing's. It's a true Cushing's. Now you start the real evaluation. First look at ACTH. If the ACTH is high, that means it is ACTH dependent. If the ACTH is low, then it means ACTH independent. ACTH independent means problem is with the adrenal gland. Go do a CT of the adrenal, you will find the pathology. Very simple. But if the ACTH is high, there are two possibilities. The ACTH is from the pituitary or it's from some other malignancy, we do not know. For that, we have to do high dose DEXA suppression test. What is high dose DEXA suppression test? In low dose, we have given 0.5 mg of DEXA every 6 hourly for 2 days. In high dose, I will give 2 mg tablet of DEXA every 6 hourly for 2 days. And that will suppress the cortisol or not suppress. If that is suppressing, that means it's a Cushing's disease. It's arising from the pituitary. If it's not suppressed, that means it is ectopic ACTH production. If they are equivocal, it's not looking like suppressed or it's not looking like not suppressed, just a midline value if it's there means you are confused. Then you can do one thing. What thing you can do? You can take a sample from the petrosal sinus and you can take a sample from the blood and you will compare ACTH. If the ACTH is more in the petrosal sinus means the origin is from the pituitary. If the ACTH is more in the periphery, that's in the blood, means the origin is ectopic. So you can go for petrosal versus peripheral ACTH ratio. And if it's more than 2 means it is because of pituitary. If it's pituitary, go do surgery. Pituitary adenectomy. If it's malignancy, treat the malignancy. If it's adrenal, do adrenalectomy. Very simple, right? Treatment of Cushing's is easy, but evaluation of Cushing's, you have to have some concept. So because it's difficult and confusing, let me tell you once again, what is Cushing's syndrome? Because of high cortisol, patient will have moon-like facies, buffalo hump, central obesity, purple striae, and hypertension, hyperglycemia. All these things will be there. So you suspect Cushing's. What are the causes of Cushing's? It is ACTH independent and ACTH dependent. ACTH independent means some problem with the adrenal cortex. That is less common. But ACTH dependent is most common. So the origin of ACTH can be from the pituitary or from some malignancy, ectopic. So while doing evaluation, first thing is it Cushing's? After that, I will see whether it's ACTH dependent or independent. If it's ACTH dependent, whether it's pituitary origin or from the ectopic. These are the steps I will follow. So immediately after knowing it as Cushing's, first I will do serum cortisol or urine cortisol, 24-hour urine cortisol, or salivary cortisol. Obviously, it will be elevated. The next thing I will be doing is low dose DEXA test. Low dose DEXA suppression test. Why low dose DEXA suppression test? It will help me to differentiate whether it's a true Cushing's or pseudo Cushing's. Not suppressed. What not suppressed? Cortisol. Cortisol not suppressed, it is true Cushing's. Cortisol is suppressed, it's pseudo Cushing's. So once I know it's true Cushing's, the next step I will do is ACTH. If ACTH is high, it's ACTH dependent. If ACTH is low or normal, it is ACTH independent. So ACTH independent means where is the origin? It's from the adrenal. Go do a NCCT abdomen. You will find out what is the abnormality. If there is abnormality with adrenal gland, remove that gland. But if it is ACTH dependent, my doubt is whether it's pituitary origin or ectopic origin. Now I'll do a high dose DEXA suppression test. So low dose DEXA suppression test is to differentiate from true Cushing's versus pseudo Cushing's. High dose DEXA suppression test is to differentiate between ACTH dependent, pituitary or ectopic cause. High dose DEXA suppression test, pituitary or ectopic ACTH. So with high dose DEXA, if it is suppressed, it's pituitary. What is suppressed? Cortisol is suppressed. If cortisol not suppressed, it is ectopic. But if it is equivocal, what you should do? If it is equivocal, you have to go for petrosal, inferior petrosal sinus sampling. And you have to measure the ratio of ACTH. How much is the ACTH in the inferior petrosal sinus? And how much is the ACTH in the blood? And if the ratio is more than 2, the origin is pituitary. So if more ACTH in the inferior petrosal sinus means the ACTH is coming from pituitary. If its ratio is less than 2, it's ectopic ACTH. So ectopic ACTH, do a PET scan, identify where is the malignancy and treat that malignancy. If it's pituitary, go for pituitary adenectomy. Very simple. Treatment is simple. So this is about Cushing's. Let's go back to the question. The question is, this patient is having central obesity, hypertension, purple striae. Yes, it's looking like Cushing's. They have done the serum cortisol levels. It's elevated. We don't know whether they have done low dose dexamethasone test and ACTH. Directly they have given that it is suppressed with high dose DEXA. That means it is a Cushing's disease. It's definitely not adrenal insufficiency. It's not adrenal adenoma because if it is ACTH independent, we are not doing high dose DEXA suppression test. And ectopic ACTH, cortisol is not suppressed by high dose DEXA. Very simple but confusing. Okay, coming to the next question. It is a 55-year-old male. He came to the OP with a 3-month history of progressive shortness of breath and dry cough. So since 3 months, it's shortness of breath and dry cough. What do you think? So whenever there is dry cough, there are only 2 possibilities. It's the interstitial disease in the lung or it is a pleural disease. Whether it's airway disease or parenchymal disease, there will be cough with sputum. So the interstitium of the lung is involved or the pleura is involved, only then there is a dry cough. So we'll see what is involved. And this person is a smoker, chronic smoker, very good. On examination, there are bilateral crackles and clubbing of the fingers. So based on the history, shortness of breath with exertion and dry cough since 3 months, I told you it could be pleural pathology or interstitial pathology. On auscultation, there are bilateral crackles and there is clubbing of fingers. So this goes with interstitial pattern or pleural pattern. In pleural, if pleura is involved, then there should be decreased breath sounds. It's not like there will be adventitious sounds like bilateral crackles. Bilateral crackles are seen in interstitial fibrosis, that is ILD. So this is going with interstitial involvement. So let's see. So let's think it's probably ILD. And they have done a pulmonary function test with normal FEV1 by FVC ratio and reduced FVC. What is this? It's obstructive pattern or restrictive pattern? It is restrictive pattern. So restrictive pattern with interstitial involvement is nothing but ILD. And the chest X-ray is also showing bilateral reticular involvement. So it's like this reticular involvement. It's like laces. The opacities are like this, if you observe, reticular opacity seen in ILD. So what is the most likely diagnosis? It's idiopathic pulmonary fibrosis. Let's rule out other options. Why it's not COPD? This person is a chronic smoker and since 3 months he's having symptoms. Why it's not COPD? What is the presentation of COPD? COPD, it's an obstructive pattern. But what is the pulmonary function test showing here? It's restrictive pattern, right? This is a obstructive. Asthma is also obstructive. Bronchiectasis is also obstructive. This is restrictive. So in the exam, if you are not able to understand, so just based on history, diagnosing a case is a bit difficult at your level. So he is very intelligent. He has given you this key point. He knows that you cannot identify that based on the history. So he has given you this key point. So just based on restrictive pattern, you can be able to differentiate this. So in question, there will be multiple key points. You can diagnose at any key point, but the one most appropriate to choose, that will be developed with integrity and solving the questions and presence of mind. Even if you don't know the X-ray, even if you don't know the presentation and examination findings, this obstructive restrictive pattern is a very basic thing we learn, right? Okay. So coming to idiopathic pulmonary fibrosis, we don't know the cause. The name itself is saying that it is idiopathic. So how can you treat it? You can give anti-fibrotic drugs, but it will not reverse the fibrosis. It will just slow down the progression. The drugs are perfenidone and nintedanib. Yeah, it's given here. Perfenidone and nintedanib are anti-fibrotic drugs which will inhibit your TGF-beta. I cannot say these drugs are curative, they will make a whole change in the lung. No, they will just slow down the progression. And the quality of life of these patients is very bad. It's very morbid disease. They will have shortness of breath on exertion. They have to be on home oxygen. So oxygen supplementation is very important, and in advanced cases there is nothing you can do. The only thing is lung transplantation. And in lung diseases, the important thing they can ask you is which are the smoking related ILDs. There are many types of ILDs. You should know about non-specific interstitial fibrosis, usual interstitial pulmonary fibrosis. And what are smoking related ILDs? Smoking related ILDs are your respiratory bronchiolitis ILD, desquamative interstitial pneumonitis, Langerhans histiocytosis, and idiopathic pulmonary fibrosis, the thing you have seen here. And idiopathic pulmonary fibrosis are of two types, UIP and non-specific pattern. So the difference between non-specific and UIP is, non-specific pattern is a bit mild, whereas UIP it's a bit severe. And if you look at the HRCT, in NSIP pattern, there will be few ground glassings. But in UIP, there will be pavement pattern. It will be a mild GGOs here, but here it's like a pavement. It's the arrangement of tiles. Okay. And almost all your connective tissue disorders, they have lung involvement of ILD, and the most common will be NSIP, except rheumatoid arthritis is associated with UIP pattern. All diseases, it's NSIP. Rheumatoid arthritis is an exception associated with UIP pattern. These things you should know. So your idiopathic pulmonary fibrosis, both UIP and NSIP pattern, is smoking related. Your desquamative interstitial pneumonitis, respiratory bronchiolitis associated, and Langerhans cell associated, all these are smoking related ILDs. These are the important things you should be remembering in ILD.